This session on psychedelic clinical practice was actually curated by my colleague Hattie Wells, who can't be here today. So the lovely Claudia Canavan stepped in to moderate this session, and Claudia is a health journalist, and I think it's really great to have some fresh perspectives on our panel instead of hearing from the Breaking Convention crew all the time. So please give a warm welcome to the clinical practice panel.
Hello everyone, and welcome to today's session on contemporary clinical practice, where we'll be exploring the current state of psychedelic clinical practice, what's going on in the sphere, the potential of different approaches, and the current challenges. My name is Claudia Canavan, and I'm a health journalist. Joining me to discuss are three eminent voices in the field: Ashleigh Murphy-Beiner, Rosalind MacAlpine, and Carolina Maggio, who will kindly introduce themselves to you now. Ashleigh, could you go first? You've got the mic.
Hi everyone, I'm Ashleigh. I'm a clinical psychologist and I'm working in the NHS. I work in a specialist trauma service, and over the last 6 years I've also been working as a research therapist and doing psychedelic research into predominantly participants' experiences of the clinical trials that we've had at Imperial College London. So for depression, for anorexia with psilocybin, and then DMT for depression. And I've become very interested in that because of just really wanting to, I heard the question earlier, just think about participants' experiences being kind of right at the forefront of how we think about treatments and how we develop the treatments. And I've also been doing some translational psychotherapy process research, so to help us try and bridge the gap between clinical trials work that we do and what it will be like using psychedelic-assisted therapies in clinical practice, and in the NHS and in other settings. And along that kind of journey, I've also got very interested in ethics, because of really the complexity of being in the room with people and trying to navigate the therapeutic process and to understand that better. So yeah, that's a bit about me.
Cool. Rosalind, could you take it next? Sorry.
Hi, I'm Rosalind. It's really nice to be here on this panel today. Last year was my first Breaking Convention, and actually my first ever proper presentation from my PhD, and it was all about psychedelic preparedness. And so naturally, I quite meticulously and neurotically prepared for the presentation. And naturally, when it came to actually doing it, the slides were completely corrupted, and I had to do a kind of ad-lib improvised performance of whatever the psychedelic preparedness was. So my hands became graphs and my preparedness became redundant. So it's very nice to be here today without any slides, and in a situation I can't really prepare for. My academic background is in experimental psychology and developmental neuroscience, and I'm currently on a mental health science PhD program at UCL. And a large part of my research focuses on psychedelic preparedness, as I said. So the state preceding the psychedelic experience, which is conducive to a more safe and personally meaningful experience. And as Andy mentioned in the previous panel, it's a big question as to whether someone can ever truly be prepared for something as kind of ontologically shocking as a psychedelic experience. But we try to define it as a state of being psychologically, physically, and socially ready for not only the content of the experience, but also any consequences that may arise as a result of the experience. So a large part of my research has been around developing and defining this concept, and then exploring preliminary kind of predictive efficacy of this state on both the acute experience as well as therapeutic outcomes. And I'm currently working on looking at the role of meditation as part of this preparation and whether or not that has an effect. So yeah, I'm really excited for this panel, really looking forward to the rest of the conference, and thank you for having us.
Cool. Carolina, could you go next?
Thank you. Wonderful to be here. I'm a research therapist at the Institute of Psychology, Psychiatry and Neuroscience in King's College London, where we are investigating the therapeutic applications of various psychedelics. Some classic psychedelics like psilocybin for patient population like treatment-resistant depression, post-traumatic stress disorder, functional neurological disorder, and soon we will start also with anorexia nervosa. We also completed recently the last trial from MAPS for MDMA-assisted therapy for PTSD. And we are about to start one with Methalon for PTSD. And we also about to start a 5-MeO DMT trial for TRD after completing the healthy volunteers last year. It's, as you can see, it's a variety of substances, a variety of patient groups. Some of these trials are funded by the NHS, some are privately funded. So I hope today I can share some of my experience in what does it mean to work across these different experiences.
Cool, thank you so much, guys. Let's start by talking about the role of the therapeutic relationship in psychedelic therapy. We've seen a growing trend, perhaps a lesser emphasis on this relationship and a greater emphasis on the drug part of the treatment. It would be good to know if each of you has observed this, and if so, what you make of it. Ashleigh, could we start with you?
So, I suppose with the therapeutic relationship in MDMA-assisted therapy and psychedelic-assisted therapy, I think many of us think that that's very fundamental. And I work in trauma, and I kind of specialize in working with people with trauma. And it's, well established that lots of people who are diagnosed with lots of different diagnoses will have early life relational trauma. It's one of the kind of strongest predictors of adult mental health difficulties. So why I'm talking about that specifically is because of power, thinking about power and the therapeutic relationship and how we hold that. And given that there's been such a kind of limited amount of thinking so far around the therapy side of things in psychedelic therapy, we're not actually thinking so much around the role of the therapist in terms of the research. So as clinicians, we are, because we're faced with it every day. But in terms of the actual research that's being produced, we're not thinking as much about the role of the therapist. And that's what I've been trying to investigate much more. I suppose the things that we think about all of the time are trust, being able to establish trust. But that's kind of the beginning of the whole process, I think. And the therapeutic relationship also means different things to different clinicians. For some people, it will be a way of providing enough safety for a person to be able to benefit from a specific psychological model, whereas for somebody else, it will be the mechanism of change. It will be the process of change. It will be relational healing. So I think there are different ways to think about the therapeutic relationship, and I think it depends on who the clinician is, what their training is, what their background is. But I think it's something we need to be thinking about much more, because what actually is there in the room is an enormous power dynamic between the client and the clinician, and that's something that really needs to be thought about very carefully.
Thank you. Maybe what I can add to that is the challenge of attempting to understand what the therapeutic relationship becomes in terms of the power that it holds in the psychedelic experience and in the treatment with our patients. Because we are in a specific time in history where there is a little bit of an enamorment with the molecule, we're still working within a framework, a medical paradigm that is primarily biomedical. So even when it comes to the development of these treatments, most of research is still dealing with feasibility, with safety, with effectiveness. There is a much less focus on all the extra pharmacological aspects of psychedelic therapy, which we have seen for decades and decades of how important they are. Nonetheless, we know is important, but it remains that elephant in the room in research that doesn't really go as far as, for example, what the FDA needs in this stage in time in order to be able to pass these drugs, to be able to be regulated. So it's a bit of a contortionist act to work in psychedelic research and think about the therapeutic relationship. We know that the therapeutic alliance is central. We are still struggling to prove it empirically, but it's a little bit the nature of psychedelics. In a way, working in psychedelic research or being part of the psychedelic field, it's a psychedelic experience. It's very paradoxical. It's filled with lack of capacity to define. We know that we are part of the experience as we observe it. We know that we hold tremendous power in the room as we sit with our patients. And at the same time, we are not really agreeing on a framework that can allow us to make sure that that power is held with great respect and care. So I think there is a lot of anxiety around that. So, the role of researchers or therapists is to do our best to continue learning on the sidelines and do publications so that all that important data doesn't get lost. But unfortunately, it doesn't get through the bigger publication that influence how we think about these treatments. I hope this is the future, that we are looking into when, we'll get to the point of being able to make use of these medicines within the medical system, that we will really take in really careful consideration the role of the therapeutic relationship. Not because the therapist is the most important person, but because it is an ingredient in the experience, and all the ingredients in this experience needs to be looked at with equanimity and with care.
I think it's true what you said. We need to find a kind of balance between these two competing views, because on one hand, you do have some researchers like Guy Goodwin recently wrote a paper essentially arguing that the drug does do a lot of the heavy lifting, and it might not be strictly necessary to have kind of a strict psychotherapeutic approach or relationship alongside that. And this obviously does have some merit when we think about the impressive dose-response relationship seen in a lot of the psychedelic trials, but I think it would be a mistake to completely dismiss the therapeutic relationship altogether. Even if we do move towards a more streamlined approach with a more minimal model, the therapeutic relationship is undoubtedly vital to not only the safety of the participants, as you both mentioned, but for some people there may be the kind of corrective relational experience of being compassionately witnessed on a non-ordinary state, may be healing in and of itself. And so I think the real question isn't whether the relationship is important, but how we can conduct research to really distill the most important relational elements, which may be apparent across various treatment modalities. It's not necessarily if or, but both and, so we can hold space for the pharmacological and the relational.
Great, thank you. We talk a lot about the different drugs used in psychedelic therapy, psilocybin versus MDMA, etc. I think we speak less, though, about the various psychotherapeutic methods to pair with psychedelic treatments, from CBT to more traditional talk therapy. Can we talk about which methods each of you are currently working with? Ashleigh and Carolina and Rosalind, I'll come to you about your research separately. Could Ashleigh start?
Think about it. It's not an easy answer, actually, because, again, even at King's, where we're working across studies, some studies have a much more strict framework. MAPS is one very well-known one. It was almost like the archetype of psychedelic therapy training, for example, if you will, the golden standard. What we can see across all these different approaches is that the same things that we've seen since the 1950s when psychedelic therapy was beginning to be studied, is that it was being developed along humanistic psychology, so concepts like person-centeredness, non-directiveness, positive regards, congruence. These are all things that we see across every study. I think the idea of non-directiveness is often misunderstood, often is thought of as the therapist just sitting back and see what happened. Is not that at all. In fact, there is so much happening, but the point is that the therapist attempts to interfere as little as possible with emerging contact within the psychedelic experience. This approach, it's again across every study, and sometimes is described as based on this idea of noetic experience, of inner knowing, of inner healing intelligence. You find it sometimes as used as a framework or a formulation in therapeutic approaches. The idea that no matter how much your role as a therapist can support and facilitate a specific experience, you're not there to guide, you're not there to direct, you're there to facilitate the emergence of that noetic quality, of that inner capacity, that a person that, particularly if you think about someone with treatment-resistant depression, who has maybe felt failed by the medical system for decades, or they feel that they failed themselves for decades because their illness simply cannot be resolved, and they are highly identified with what is defined as their illness. For them to be able to retrieve that capacity to connect to what was the sense of self before the traumatic experience and the devastation that came from it. If there is a therapeutic formulation or approach that can support that, that seems to be what is more conducive to good therapeutic outcomes.
Yeah, so having had a moment to think about it, there's a lot to think about there. I think that I approach this in quite an open-minded way around what psychotherapies we might use with MDMA or with classic psychedelics, and in a way feel that there's a kind of the possibility of a kind of tribalist sort of mentality that we can get into, where we kind of think one therapy might be better than another, and actually I think that can kind of shut down some of the creativity and the kind of development of the field right now. Like, actually, we're really learning around what kind of I was about to say what the best psychotherapeutic method will be to pair with these experiences, but I think even that is a kind of false statement or question or line of inquiry, because if we actually look at the psychology research, what we know is that the therapies are more or less effective. You know, we can't really find a clear difference between different psychotherapies. So I think the other question that we're thinking about with this in psychedelics at the moment is, you know, what are the options available to us? So there's this kind of development of a basic psychological support model, which is minimal psychotherapy. And then we have the evidence-based treatments. And that, you know, that's kind of like putting a psychedelic with a treatment that we know already exists. But there might be kind of, you know, like acceptance and commitment therapy or cognitive behavioral therapy or psychodynamic therapy. And the issue there then is that we start to, we know that the evidence is there for this particular therapy, but the psychedelic experience is enormous, and to imagine that we can contain it and support it within this therapeutic approach needs quite a lot of consideration and thinking about what we might include and how we might put those things together. And that's obviously being done, and it's being done effectively. And then there are people also now developing more trans-theoretical models, which try to bring multiple different ideas together. So, and I think that's sort of speaking to the reality of what a psychedelic experience can contain for somebody, even in a clinical setting. You know, it can be a mystical or spiritual experience. It can be a profoundly somatic experience. And those are two elements, for example, that are in the Embark model that's being developed by Alex Belser in the US and Bill Brennan and their team. And I think that, you know, also has its kind of pros and cons, but there's these really very different approaches that are being developed. And I think at this stage, what we really need is this diversity of approaches, lots of creativity, lots of seeing how participants experience these different treatments. What do they say about them? How do the therapists experience them? What are we leaving out? Because inevitably we will be leaving something out of all of them. So yeah, I think there are more questions than answers at the moment.
Thanks, Ashleigh. Rosalind, I know you've been researching in more natural settings as opposed to the lab, such as the Tandava Retreat Center in Mexico, where you were part of the team monitoring participant responses to 5-MeO-DMT. I'd love to hear about that and how participants' experiences compare with more clinical settings, or if you have thoughts around clinic versus retreat in terms of therapeutic efficacy.
Yeah, we have been doing lots of research in retreat settings, and I think so the first part of my PhD was mainly looking at psilocybin in retreat settings, and then in January we went with a team of us to Mexico to look at 5-MeO. And you mentioned the differences between retreat settings and clinical settings, but I think it's also important to remember the differences between retreat and retreat settings as well. And so with the first round of research with psilocybin, just looking at the acute experience at a retreat center compared to a clinical trial, there's already so many differences. The retreat center ceremonies, obviously there's a big diversity across various different retreat centers, but generally are held in a group setting, they're outside, they're in nature, there's kind of live music, there's scents, there's a whole kind of multi-sensory environment to be experienced during the ceremony. And if you compare that to the clinical setting, it's often usually one person, therapist, medical setting, kind of a standardized playlist, etc. So already there's huge differences there, which we can unpack. But then I think it's also important to remember that those ceremonies happen within the context of a whole retreat, and these often span 3 to 7 days. They're kind of interwoven with a tapestry of different activities like meditation, yoga, breathwork, ecstatic dance. There's often a whole menu of nice options to choose from. And so isolating the kind of clinical efficacy of one of those ceremonies against a clinical trial it's almost comparing apples and pears, because it's very much this assisted quality. So we talk about psychedelic assisted psychotherapy, and I think within the context of the retreat, this language really kind of holds true. It's definitely kind of psychedelic assisted retreat or psychedelic assisted multiple experiences. So it's really, really difficult to make those direct comparisons. If we had just the ceremony and just the clinical experience, I think that would be easier. So naturally, we do see really large improvements in well-being after these retreats, but it's hard to isolate and distill specifically what that was caused by. And I also think there's huge merit and importance for these standardized procedures happening within research settings and clinical trials. And so with our research with 5-MeO, there's obviously much less research. And just on a kind of a drug level, 5-MeO is phenomenologically very different from psilocybin and other psychedelics. And we had the opportunity to conduct this kind of research at UCL, but we decided, given the kind of current state of 5-MeO research, it kind of made a bit more sense to bring the lab to the retreat. But this time around, given what we kind of know about the diversity and kind of variability around retreats, we wanted to create a retreat which was as standardized as possible. So rather than us joining kind of an existing retreat, we kind of set up a series of science retreats where the facilitators would create a standardized session and procedure for all 30 participants. So the same playlist, the same kind of facilitation, trying to bring as much of that kind of standardized scientific mindset as possible to the retreat setting, whilst also incorporating the expertise of participant care that these facilitators of 5-MeO have, which we definitely don't have, or we don't have yet, at least within our research team. So that was a kind of symbiosis, we kept calling it, between the research and retreat type settings. And within that study, we weren't looking at clinical populations. So we were bringing in healthy people with lots of 5-MeO experience, and we did see improvements in well-being, but naturally there's ceiling effect. So they came in well and they left weller. So I would like to see more research happening within the clinic and also within the retreat, and see how we can kind of learn something from both sides of this kind of world and this experience.
Cool, thank you. So when it comes to clinical practice and psychedelics, ethics are, of course, this huge consideration. And there's a few things to talk about here. First off, what are the ethics around dosing people with strong psychedelics without psychological support or with a very minimal therapeutic approach? Rosalind, you've got the mic. Do you want to just crack on? Or do you need a break?
I need a break.
Ashleigh, take it.
The ethics of dosing with minimal therapy or psychological support. I suppose those are different things. The psychological support model and the minimal therapy, because the psychological support suggests that it's not therapy at all, but I think in reality, that's quite difficult to achieve when a clinician is in a room with somebody for many, many hours and they're trained to work clinically. So, I mean, I touched on it in the beginning, the power dynamic in the relationship is, I guess, what lies at the heart of the ethical complexity in psychedelic-assisted therapies, because somebody is already vulnerable because they're coming seeking treatment for a mental health difficulty, and then we give them a psychedelic, and if it's MDMA, then they're opened up and more trusting and more socially connected, and that creates the possibility for being more open and receptive to the clinician. And on the psychedelics, you know, with classic psychedelics, people will be going into potentially very profoundly altered states of consciousness where they are losing sense of time, and boundaries are dissolving, boundaries between self and other, the self and the therapist, and also all of the normal clinical boundaries are, you know, very different in this kind of setting. So usually you'll be seeing somebody for an hour a week, but in these kinds of treatments, people are together with their therapists for many, many hours in these profoundly altered states of consciousness. So the potential for maintaining, you know, the therapeutic boundary, not the potential, but like the difficulty of doing that, and also that part of the treatment, or the kind of thinking in the treatment, is also the kind of humanity in being together in the treatment process, with there being some dissolving. There's a lot of kind of suddenly fluidity in the setting and in the relationship, and that brings with it all sorts of dilemmas, you know, in terms of relating. And I'm thinking about even a very kind of, again, I guess coming back to trauma, because that's, you know, what I work with so much, people who are very, very traumatized, that there's the possibility of all kinds of reenactments of feeling neglected or abandoned, because, you know, imagine that a clinician is there for a very long time, and then they start to become tired or something like that. You know, all of these very small kind of ethical difficulties come up, as well as the very big kind of things that we think about, and that might be, for example, at the beginning of the process, informed consent. How do you even let somebody know really what they're going to be experiencing? And actually, we think probably you can't. Probably that's not possible. And ethicists are moving more and more towards now saying that perhaps we should be thinking about the consent process as consenting, like we do in society and culture, to having a baby, for example, to having a child. And the analogy, like why there's a kind of comparison being drawn by those things, is that people talk about those kinds of experiences as transformative. So having a child, you can't, people will tell us, you know, you can't know what that's like until it's happened to you. You won't know. And there's something about the psychedelic experience also that has that quality that you actually just really won't know until afterwards, fully. But in terms of kind of that transformative experience of having a child, we do have a sort of cultural understanding and a kind of cultural touch points and social touch points with each other, you know, to roughly know what it might include and what it might be about to do that. And so actually, in terms of ethical issues and consent, that's one of the things that we need to really think about. How, because we don't have cultural frameworks really, do we, for holding these experiences. So what is it that people need as a kind of holding framework to be able to say yes to participating in a very transformative type experience? There are lots more, so maybe I'll pass over to Carolina.
I'm going to move on to the next question, actually, just because we've got a few more to get through, and I want to make sure we've got time for audience questions. But Carolina, could you take this one? What's also true, of course, is that with mandated therapists and therapy and psychological support, there's potential for costs to be really, really high. and I'm sure we've all seen the costs of such interventions in Australia, it brings issues of access up. So what do we think about this? How might this be navigated? What do you think, Carolina?
It's a huge concern, and I don't think we have at all figured out what that is going to look like. I mean, we can suppose that if the treatment is too expensive, even in moments when, at the time where the NHS will try to deliver it, and people will not be able to afford it, the treatment will not be delivered. So whoever has stakes on trying to sell this treatment at very high prices will have to bring the cost down. But again, these are speculation. I think we're all really concerned that these treatments become elitist, that there's going to be real issues with accessibility. And then again, there is the paradoxical idea that these are extremely ancient compounds found in nature, and they really cost nothing. So why the production of these substances has to be so, incredibly high? What seems to be expensive at the moment is the time of the therapist. So that's one of the reasons why often sponsors are trying to cut that down. That's what seems really a little bit, with the attempt to reach an objective, which is the objective of being able to deliver these treatments. And we see what are the costs, for example, the time with the therapist. Concepts are brought forward, such as perhaps the therapeutic relationship is not that important. It is important, it is very expensive at the moment, and it doesn't have to be. I think one way to go forward with this until we don't have a better solution is to stop thinking in such a one-to-one approach with our delivery and more into a group collective approach, which is anyway how it's always been done traditionally. And we have a lot to learn from that. We are probably the only society that could conceive illness as an individual experience. Traditionally, in ancient practice, when psychedelics were used for healing, was always conceived as illness of the community, even if one person within the community was sick. So we are now, in fact, in the process of designing trials for psilocybin for PTSD, where we're going to do group preparation, group dosing, and group integrations rather than working one-to-one.
Great, thank you for that. Ashleigh, I'm going to hit you with a different question. So when we're talking about ethics, we need to mention the potential for serious adverse effects or almost serious adverse effects. Recently, concerns have been flagged about such events being unreported or minimized, even left out of scientific literature. Do you have thoughts on this, and how might those who've suffered challenging experiences be supported post-treatment and longer term? Are there medical providers who could take on a referral for somebody dealing with extended difficulties? And how do we navigate this?
I think this is one of the biggest challenges that we're facing because our trials are short term at the moment, and healing is often a much longer process than is offered and kind of created for people in these settings. And I think it's a real, maybe let's locate this in the kind of socio-cultural context that we're into, in psychedelics being illegal and desires to kind of legalize and, have the possibility to have them be used by people. I think there are enormous kind of pressures that might create the conditions in which there could be a wish to suppress or to minimize or to not see even, not even willfully potentially, but just in looking away. But that leaves participants who experience challenging experiences in a very, very difficult position. And what I think, a bit like Carolina was talking about with group, the actual treatment being group-based, that actually in the aftermath of challenging experiences, one of the things that people really need, we need each other after those experiences. and some way of containing together that something very difficult has happened during the psychedelic experience. And often people will then, move, if there's enough support, if there's enough kind of frameworks, people can move through these challenging experiences. And often, people will really talk about afterwards and that this has become a very important part of the whole healing experience for them. And I'm not talking about ethical transgressions here, I'm talking about challenging psychedelic experiences, just to be clear about that, which involve kind of emotional struggle or difficulty with, coming to terms with something that's happened, or the ontological shock. But that, that's something that Peter was talking about earlier. Clinically, as psychotherapeutically, there is a big gap for bringing in frameworks that help people hold those experiences when they have them. So that's something that we try to do in integration groups, for example, afterwards with people, to be able to learn from each other, from how others have navigated and survived the experiences. There are lots of other things that can help in terms of practices and sometimes therapy, but I think it's a very individual process.
Rosalind, do you have anything to say on that?
Yeah, I think what you said is very, very important. And I think as part of psychedelic therapy, it's important to recognize that as we see more trials with larger numbers of participants, what we describe as kind of serious adverse events or challenging experiences may be part of the experience. It may not be that the experience has gone wrong, and they may occur even with best practices, with psychotherapy, with no ethical breaches. And I think it's really important as researchers and clinicians and as a community, we know how to recognize, manage, and respond to these. And as Ashleigh mentioned, the lack of kind of long-term follow-up with kind of enough contact points between follow-up sessions may be one way in which we're kind of having people slip through the net. And these things probably will continue to arise as we do more psychedelic research. So it's about creating a framework for best practices for monitoring these. I think recently Roman Politsky published a kind of framework for this, and there were, I think, 50 or somewhere between 50 and 60 items that people can look out for. But currently there isn't a strong framework and there isn't a kind of standardized way of looking into this. But I think we're learning so much through research, and I'm hopeful that as we do more research with more participants, that there will be a better framework.
Thank you. So we've touched very briefly on ethical transgressions, and of course another concern when it comes to psychedelic therapy is that of unscrupulous practitioners, and we have seen rare, but there have been instances of abuse happening. The case of Richard Jensen and Donna Dreyer, who abused Megan Busson in a MAPS MDMA PTSD trial in 2015, which came to light in the 2020s. Do we have any thoughts on how people are suitably vetted and protocols are implemented to deliver such treatment in as safe a way as possible? Does anybody want to take that first?
This is possibly one of the biggest concerns of psychedelic treatment. What happened, from as far as I understand, with the situation is that aside of various aspects of why those clinicians were not suitable to do that work, they were not supervised, and the video of their sessions were not supervised. When you look at those videos, if we can touch for a moment just to have an example, there are a number of things that are horrifying, aside of, spooning with your participants in bed. But what is even more horrifying is that when you notice that the participant, who was a woman who survived sexual assault, tried to move away from the therapist, you could really see the narcissistic wounding in the therapist of feeling rejected. So the problem with a therapeutic approach that is not considered therapeutic is that there is a number of important monitoring of the approach that are not in place. For example, supervision is not a requirement, unfortunately, in research settings. We choose to have it because it's the most important thing for any clinicians that know, how easy it is to have blind spots, but it's not required by protocols. There are no professional bodies that regulate psychedelic therapy at the moment. So even if someone abuses the participants and then get fired, they can't always go and work underground. So at the moment we find ourselves in the Wild West, really. And I think what's going to be really important is to have rigorous and robust supervision and way to, professional bodies and licensings that every therapist can have to respond to, and if a participant or a patient have an experience of being abused or any ethical breach take place or any boundaries is broken, that they can go to and speak to. At the moment, this doesn't exist, so there is a tremendous fragility in the field. I think maybe just I want to add that we touched on the idea that psychedelics we know produce a highly suggestible state, but they also produce potentially a strong idealization towards the therapist. And at the same time, this can happen while there can be a powerful ego inflation in the therapist. It's not unusual that you hear underground practitioners that see their, I wouldn't say this is not unusual, but it's very easy to, let's put it this way, everyone calls each other a narcissist in this field. And so I think, at some point we have to look at ourselves and try to understand we need each other. We need each other to continue develop awareness on our limitation, especially, as we said, when there is such a powerful power differential that become enhanced in the psychedelic space.
Ashleigh, do you have anything to build on there?
I just really, really agree with everything that you've just said there. I suppose just the one thing that was going through my mind as you were speaking is just what a pain, like how painful it is in our field to know that these sexual transgressions have happened and do happen. I think we all bear that together, and I think that from that can come a kind of wish to imagine that we can eradicate it with rules and guidelines. And I think that's why I agree with you so much, because I don't think we can. I think it can be very difficult to detect in somebody. It could be very difficult to detect, and also because transgressions often are happening not from people who set out perhaps intentionally to get into a profession to perpetrate. Of course, those people exist, but others who the boundaries slip bit by bit, and that we're all fallible to that. We're all fallible to those openings to act from a place of our own needs and our own wishes rather than the wishes and needs of our clients. And so that's why it's only really, I think, not only, but perhaps the most important part is the training, that we're really training people about ethical practice. What does that mean? In our traditional trainings, we've talked very little about how to make decisions ethically, in the moment. And that's something I've really been working on. I think we really need to create spaces where we can be honest as well, because if we need to be able to prevent harm from occurring, people need to be able to talk about when they feel that they are stepping in a direction which is not in the client's best interest. Thank you. And I think that's difficult with that pain that I kind of touched on in the beginning of this, that it's hugely activating for all of us to know that sexual transgressions happen, or any serious transgression, and it stirs a lot up within us. So, I think it's very delicate work, and it's about the holding, containment and training of the clinicians over very prolonged periods of time and carefully,
Rosalind, have you got anything to build on there?
I completely agree with Carolina and Ashleigh. I think the external auditing and teamwork is super important, as well as training and honesty. And not much more to add other than this will likely involve difficult conversations, and therefore it's important to hold spaces for honesty and transparency, and essentially putting participant well-being over and above loyalty to any personal or institutional ties.
Great. We've got 15 minutes for questions from the audience. So do we have somebody who can pass the mic out? And there's a static mic. Oh, awesome.
Hi to the four of you. Thank you so much for that. I don't think you can see me, but probably. Anyway. And my question's around culture sensitivity in the clinical practice and culture sensitivity in the clinical practice. The three of you are in different, of course, clinical practice around. And I just want to see the overview of, because it senses from the outside, from the public perspective, that there is a big gap around the culture diversity and so on. And I wonder if you feel that too, and how, with your own practice, how is that being approached inside the clinical practice that you are at the moment? If there is talks around it, and how is that being kind of like communicated? And and if you see that going somewhere and that gap being shortened, and how to, thank you.
Anybody want to take that one first?
I agree with you that there is a big gap at the moment between, being able to be offering probably what I would call culturally responsible care. And I'm thinking about the work of Sarah Reed. So we're very fortunate, Imperial, to have Sarah Reed, who's doing, really amazing work around this. And I think my thinking's been very influenced by that, in terms of, when we say cultural, that we're thinking about the whole person and all of the different identities that a person may have, visible and invisible, and how that impacts how safe they feel to be able to engage with clinical research, which for many people has caused historic harm. In the psychedelic field, people of colour have been very seriously harmed, as have other communities. So I think that first step is sort of the awareness of, okay, how might people be relating to just the research itself? And then, stigma around drug use and psychedelics themselves. So we need to be thinking about that. And then experiences of mental health as well, for lots of different marginalised communities, are also very challenging and have historic harms in them. So the way I tend to think about this is that there are things that we can do at the recruitment stage, and the stage of when participants come through, also the kind of language that we use, being sensitive and understanding, how we might be, again, it's about power, isn't it? How we might be using the power that we have and the language that we have to create certain conditions which feel not accessible for people. And there are lots of practical measures that can be kind of done around that. More kind of diversity screening tools, very specifically asking questions in different ways. And I think that knowledge of how to do that comes from building relationships with different communities. And I think that realistically that work can be very challenging and very difficult, and it takes time, so it needs a lot of very concerted and consistent effort. Yeah, those are some of my thoughts.
So I think another element is education. You speak to a really important concern. There's been incredibly damaging unethical practice when it comes to ethnic minorities and psychedelic science, exploitation. There is an history that is, there is a reason to be suspicious of. But often it's also been spoken about stigma around the specific culture towards psychedelics. And this has been the narrative for the last 10 years. And interestingly, recent research has shown that actually that is not the case, that following psychoeducation, ethnic minority groups are very interested in participating in psychedelic studies. So this being more community-faced, I think, as researchers is going to be a very important key, because the interest is there, but the psychoeducation is necessary. Another aspect, as you're saying, with the screening and recruiting, when we started in 2018 with our first psilocybin study, I would say 94% of our participants were Caucasian. and heterosexual Caucasian. And that was because, for several reasons, pressure from sponsors needing to get participants through the door. Through the years, it became so important, well, so evident for us that we were not serving, the right purpose. So, as a team, we devised a way to use the screening process in a way that represents the true ethnic diversity of London, for example. And so we have targets for different ethnic representation, and we do our best to reach the target. Sometimes that means that we have to sacrifice the majority of Caucasian heterosexual participants that wants to get through the screenings, because we're attempting to bring as much as possible diversity and equality in our research setting. So there are ways, and I think it's possible, but it's going to be a combination of education and screening strategies.
Should we move on to the next question? Just I'm conscious a lot of people have things to ask, so sorry to cut you out, Rosalind, but is that okay?
First off, how lovely it is to have an all-female panel talking about clinical practice. So I agree entirely that somebody who's psychedelic naive can't give truly informed consent for a psychedelic experience. By bringing psychedelics into the medical model, we have to be conscious that the medical model does an awful lot of quite traumatic things to people without their consent in the name of making them better. You mentioned that, well, we should kind of class psychedelics as a transformative experience, but in doing so, you're suggesting that psychedelics are an exception to this rule that's in place to ultimately protect patients. Why do you think it's acceptable for psychedelics to be an exception to this kind of fundamental rule of informed consent?
Is anyone happy to take?
Yeah, so I don't necessarily know that they are, but that is a kind of debate going on in the ethical sphere at the moment around what is possible in terms of informed consent. So, yeah, I think it's let's maybe just also think about what does informed consent usually contain. It usually contains somebody being able to be truly informed about what they're going to experience and being able to consent. So, yeah, you're bringing up something around somebody being... not being able to consent to their treatment, not being able to consent to it, and then us kind of. But I think actually that is the reality right now. I think that is actually. I think that. I suppose what I'm acknowledging is that we are trying our very best to give people information, as much information about, what could possibly occur, but whether actually that constitutes informed consent, I think we can't say that it does. I don't think we can, and I think that's sort of what I was speaking to, and that's enormously problematic because that's not what things are usually like, as you say, inside a kind of mental health or medical model. Do you want to add anything?
Maybe just to think about maybe the flip side to the problem, the fact that in order to engage with a psychedelic experience, you have to engage with something arguably impossible, which is to trust the other. And through that attempt to trust yourself. And in a way, the medicine and the compound is acting as a symbol of this trust. Trusting the medicine, sometimes you hear saying. Ultimately, we want to allow for an experience of transformation to take place. And this is, these are not the people that you will meet at retreat settings or at a party. These are highly traumatized individuals where the concept of trust holds so much meaning. And unfortunately, because of deeply self-annihilating experiences, was attacked to the point that the very concept of self might be compromised. So it is true that it takes tremendous courage to move into the unknown in that way, and that's why we're talking about something that is so fragile. But at the same time, there might be intrinsic to this tremendous power in attempting to trust oneself and the other as part of someone's treatment.
So again, can we move on to the next question, just so that we're getting through a few before we have to wrap up? Yeah, thank you.
Hello. My question is, how important do you think it is for the therapist to have experience with psychedelics? Because like being a parent, you can't really understand or advise on being a parent without being a parent, and I think that's even more so with psychedelics.
I get this is the $1 million question. Yes. So I love to hear what you also think, but just briefly, there's nothing like knowing the path when you are walking with someone and wanting to know what are the pitfalls. At the same time, there's something very unique about psychedelic experience. We go through a psychedelic experience and often believe that others went through the same. It's very easy to take for granted that our internal world is similar to the others and that the psychedelic experience can have a point of congruence. If you are a therapist and you had experienced psychedelics and you are working with the participants, you might come with tremendous bias because you had your own experience. If you're someone who never had a psychedelic experience, you might come with a lot of insecurities. I personally think I would rather trust someone who never had psychedelic experience but moved into the space with great humility than someone who, popped acid since the 60s but thinks I understood everything about it. So yeah, I think it's very delicate and never straightforward as an answer.
Rosalind, do you have anything to say on that before we move on? Or?
Yeah, I agree. I think it's very divisive. Some people will say, I absolutely want someone with experience, and others may say it's not that important. And I think I'm on the same side as Carolina in that if someone has good skills to help navigate and support and facilitate that experience, I don't think personal experience is necessary.
Cool. We have time for one more question, so you are up.
So in terms of the power dynamics that are at play within the therapeutic space, how do you think that psychedelic therapy can be reconciled within the Western paradigm of health that traditionally sees this power dynamic with the therapist as an authority and the patient on the more passive kind of receiving end?
In a way, I think I was literally just thinking about that with this last question in terms of like what Carolina was saying is sort of speaking to when we put our own epistemological frameworks onto others. And so that I think we need to be, constantly sort of self-aware around what are our assumptions about how to do any of this. And to go back to you again, actually, the humility that we don't have, clear answers around that. We don't have certainty. And even when we have a sense of how we think things might work really well, that will just be one way of doing this work. And I think that's how we hold it in the context of the whole. And have respect and relationship, hopefully, and exchange with other ways of approaching use with psychedelics, because surely we learn more if we can actually work together and be open to the different ways of approaching things.
You got anything to add, Carolina and Rosalind, before we wrap up? All good. Right. Well, thank you so much, guys. Thank